Good evening, sir. Good evening, everyone. Please welcome to our Sahasra webinar by Dr. Jaykumar Menon. We know we need not give any introduction to the presenter today. Dr. Jaykumar Menon is a known laryngologist from India. He has done his MBS from TD Medical College, Kerala, and then his MS from Kottayam Medical College, and then FRCS from RCS Glasgow. He's also a diplomat in National Board of Otolaryngology. He has worked in Ireland and has gained extensive knowledge on phonosurgery. Presently, he's working as chief of Department of ENT in KIMS Hospital in Trivandrum. Sir, we welcome you, sir. So the stage is yours to talk, sir. Sir, your voice is muted, sir.
Yeah, shall I start sharing?
Yes, sir, you can share now, sir.
Just let me check one video, just check whether the sound is there.
Yes, sir.
Sound and video are both are there, no? Audio and video both are there?
Only audio, video is coming, sir. Audio is not coming.
I think again the same problem. There was then something Harsha told. I forgot that. How was that? I think there was some problem with that. Is there any technical?
Sir, you have to stop. Sir, Harsha here, sir. You have to stop.
I stop sharing again. Yeah, go back. Then what you do?
Optimize for motion and video.
Where is that?
When you click share screen,
yeah,
you have an option in the
right. Optimize. Okay, got it. Then what you do? Optimize both. Okay, I understand. Okay, right. Thank you. Just again see whether it is all right.
Yes, sir. Now both audio and video are coming.
Fine, thank you. Okay, so shall I start now?
Yes, sir. You can start, sir.
So good evening, everybody. Today we are talking about laryngeal paralysis and reinnervation surgeries. Now, in laryngology, neurolaryngology is a fascinating topic and it's actually developing quite fast. Laryngology is actually changing almost every day. Newer and newer concepts are coming. So we are going to talk mainly the basics of the neurolaryngology in laryngeal paralysis. What happens in laryngeal paralysis or the so-called glottic vocal cord paralysis? And what are the concepts of the reinnervation surgeries, which now, as of now, it is in the beginning stage, but I'm sure that it is going to play a major role in the years to come. So first half, we will discuss what is the basic concept of different types of laryngeal paralysis. And in the second half, we will discuss what is the basis of reinnervation surgeries and what are the types. Okay. Now, when we go to the laryngeal paralysis, of course, we have got to consider both recurrent laryngeal nerve and superior laryngeal nerve. I have intentionally kept out the pharyngeal paralysis because this is basically a talk on laryngeal paralysis alone. So I'm not going to talk about the pharyngeal plexus paralysis and all those things. So mainly we will be concentrating on the recurrent laryngeal nerve and the superior laryngeal nerve, and especially on the recurrent laryngeal nerve. We all know that it is very common, involved in, it can get involved in thyroid surgery. So this is the recurrent laryngeal nerve. We can see that during a thyroid surgery, this is actually an airly branching. Usually the nerve enters the larynx behind the cricothyroid joint, and then in the intralaryngeal part it divides, but you can sometimes get division. Now, laryngologists are getting more and more familiar with the intricate, detailed anatomy of the branching of the larynx. That is very, very important. We'll come to that a little later. And superior laryngeal, this is again the thyroid, inferior part, inferior border, superior border. Right side, you can see the superior laryngeal, and you can see the clamp on the superior laryngeal, superior thyroid artery. So it can be very close sometimes. So a close knowledge of the anatomy is very, very important to prevent these damages. So we are mainly concentrating on recurrent and superior laryngeal. Out of that, 70% will be on the recurrent laryngeal nerve alone. We will talk also a little bit about the superior laryngeal. It still remains a challenge for the treatment. Now, before we move upon, we will understand the basic physiology. You know that there are muscles supplied by the recurrent laryngeal nerve, and there is muscle supplied by the, or actually muscle supplied by the superior laryngeal. So we will just look into the physiology of each one of them before going into the details. So first we take the only abductor, that is the posterior cricoarynoid. This is a graphic representation. What the graphic representation showed is that it actually opened up the glottis at the vocal process level. You can see that again. That's at the vocal process level it opened up. But what is not mentioned here, many of the books will just say that it is an abductor muscle, or it has got only action during respiration. It is not so. It has got some action during phonation too. Especially the oblique belly of the posterior cricoarynoid tend to keep the arytenoid on the cricoid against the pull of other muscle, especially cricothyroid. So when some muscles are acting here, like thyroarytenoid and the cricothyroid indirectly, if there is no other muscle, no other device to hold the arytenoid onto the cricoid, it will actually come forward easily, will be prolapsed into the anterior part. So posterior cricoarytenoid also not only is an abductor, but it also keeps the arytenoid over the cricoid. That is very, very, very important thing. So it has got some role in phonation. Now we can see what happens when posterior cricoarytenoid is totally paralyzed. Now this concept is very important. In larynx, you very rarely get total paralysis. There could be some kind of tones. So just imagine this patient has got a left vocal cord paralysis, but we are just going to concentrate on the posterior cricoarytenoid and look what is happening. You can see that the right is paralyzed, not the left. Right is paralyzed, and the right is no movement at all. So apparently no abduction. So we know that it is the posterior cricoarytenoid is certainly not working. Other muscles are also not working. That will come later. But we are right now in this slide, we are just concentrating on the posterior cricoarytenoid. But other than that, did you see anything? You can see that the right arytenoid is actually prolapsing anteriorly and medially. And you can also see the posterolateral surface of the arytenoid here very well, which is not on the normal side. That is because the arytenoid flow anteriorly. We heard little earlier that the posterior cricoarytenoid also helps to keep the arytenoid on the cricoid against the pull of the other muscle. So the tone is lost, arytenoid fall anteriorly and medially. Don't think this is a dislocation. It is not a dislocation at all. It is actually a total tone, paralysis tone of the posterior cricoarynoid. So that is an important finding and important understanding. Now we come to the adductors. Conventionally, the adductors are taught as anterior adductors and posterior adductors. Anterior adductor is mainly, they will tell thyroarytenoid and the lateral cricoarytenoid, and the posterior adductor is the interarytenoid. I am going to change it a little bit differently, because there is some difference. Now, thyroarytenoid is the true anterior adductor. You can see that it actually increases the bulk here, thickness here, and closes the anterior half of the glottis or anterior 2/3 region of the glottis. So it provides the bulk. That's very important. While the closure at the vocal process is predominantly brought about by the lateral cricoarytenoid. So that is a little more posteriorly placed adductor. I will call it a mid-zone adductor rather than an anterior adductor. So you can see that here the thyroarytenoid is closing here. Suppose thyroarytenoid alone is gone. What will happen? Now look here. You can see that the left is not totally moving normally, but it is not totally paralyzed either. If you look carefully, you can see that at the vocal process level, it is meeting. But anteriorly, the bulk is missing. So this is an anterior, true anterior phonatory gap. And this is the case which will actually improve terrifically with just thyroplasty. Not every else. Suppose there was the gap at the lateral vocal process level, thyroplasty alone is not going to cure the condition. So this concept is very important. You can see that when pure isolated thyroarytenoid paralysis or thyroarytenoid is weak, you get loss of bulk, sometimes loss of tone too. We will see that little later. And mainly there is an anterior phonatory gap. So this is the concept about thyroarytenoid. And you also know that the most medial portion of the thyroarytenoid is known as the vocalis, or sometimes known as the thyroarytenoid internus, which is actually a relaxer of the or the reducer of the tension of the vocal. Now the mid-zone adductor, probably I'm getting a message. Larynx is requesting to annotate shared content. Shall I approve or not? What's that?
Sir?
No,
Can
sir.
you
No,
repeat,
sir.
sir?
No, sir.
Decline.
Don't approve, sir.
Decline. Okay, right, fine, thank you. Now, muscles supplied by the recurrent laryngeal nerve, you can get the adductors. Now, the second adductor or the most important primary adductor is the mid-zone adductor, which is the lateral cricoarytenoid. And here, when the contraction of the lateral cricoarytenoid happens, what happens? The closure happens at this level, at the level of the tip of the vocal process. You can see that very well. See, at that place, if the thyroarytenoid is not contracting, what will happen? There will be a gap here. But lateral cricoarytenoid is contracting. That is what we earlier saw. Now, if suppose lateral cricoarytenoid is not contracting, what will happen? Anteriorly, there may be closure. You can see that anteriorly, but posteriorly, if you look carefully, that what there is a big gap. So this patient, you can see that the posterior part, just underneath the arytenoid, there is a phonatory gap because the vocal processes are not meeting. While in the anterior half, there is good meeting, good contraction. Now, this kind of patient is not going to improve with thyroplasty because thyroplasty cannot actually correct the gap at the level of the vocal process. There may be people who say that they can put a longer flange implant or a bigger implant, but physiologically that is not really correct because you cannot really adduct the vocal process. You can only rotate. That is why Ishiki actually called it arytenoid adduction. But we know that theoretically, scientifically, it should be called arytenoid rotation because you are rotating. So that is the lateral cricoarytenoid paralysis. Now coming the posterior adductor, the true posterior adductor is the interarytenoid. So we have seen that this is the area of the thyroarytenoid. This is the area of the lateral cricoarytenoid, but this area that has to be brought by the interarytenoid, and it's quite a unique muscle in the sense that it has got two bellies, the oblique and the transverse. At least the transverse has got bilateral innervation. So you can see how does it work. You can see that now that is the difference. Here, that the interaretinode actually pulls it towards that level and closes it. But many times, if the interaretinode is powerful, even if lateral cricoid is weak, there may be an adduction. This is not an exactly correct diagram, graphic representation. We will see the rare. This is a rare condition when the interaretinode alone is involved. This happens less than 1% of your total unilateral vocal cord palsy. Now watch here carefully. You will see that the vocal process is medializing very well. And even is okay. See that when patient is abducting, it looks normal. You can see that the abduction is almost normal. When the patient is abducting, you think that sorry, why it is not up? See that it is in abduction, it looks normal. You don't think that it is paralyzed, but in adduction, what is happening? You can see that vocal process is medializing very well. Thyroid is open. Interaretinode area is actually posteriorly there is a very, very big phonatory gap. They are very difficult to correct. Neither thyroid nor aretinode rotation will correct this condition because by aretinode rotation can only rotate the vocal process level. You can close the gap. By thyroplasty, you can correct only the anterior two-thirds. So if you want to correct this gap, you have to do a procedure known as adduction aretinodopexy. You might have a doubt. You might think that, generally books tells that it is the anterior two-third, which is phonatory vocal cord. The posterior doesn't have any role in phonation. Absolutely right. But if there is a big gap, the air will leak through. So there is not enough subglottic pressure to set the phonatory vocal cord into vibration. So even if there is a big gap in the posterior glottis, it can still have a lot of voice problem.
Sir, excuse me, sir.
Hello?
Just a request from our side, sir. When you are playing the video, we are not able to hear your voice.
Yeah, so, yeah. Sorry, I will not speak.
Yeah.
Okay, at that time I will not speak. Okay, right.
Yes,
thank you. Do I need to go back to that slide?
Sir, kindly, sir.
Now, interaretinoid is the real posterior adductor. It actually brings the aretinoid, body of the aretinoid together. So it has nothing to do with the vocal process. Here you can see that. So this action, this is the area where interaretinoid act, and very rarely isolated interaretinoid paralysis can occur. This is a very unique case. Now, my incidence of interaretinoid paralysis in a unilateral vocal cord palsy is around 1%. So you can see that the vocal process level, it rotates during adduction. Abduction, it was almost normal. The anterior two-third almost closes, but posteriorly, the aretinoids don't come close to each other. And you can see on abduction, the larynx looks normal, but on adduction, there is a big gap there. Watch. So that is the vocal process, which is well medialized during adduction, but there is a bigger gap there. So this gap allows the air to leak through, consequently resulting in a bad voice, even though phonatory vocal cords are adducting near normally. Now coming to the cricothyroid. This is the tensor. We all know that, and that is only muscle supplied by the superior laryngeal. You can see the action here. So it actually stretches the vocal cord, increase the tension. And vocal cord superior laryngeal palsy has been always a problem. Even now it is a problem. There has been so many signs described. None of them are actually very convincing really, like a transversary epiglottic fold, foreshortening, all these things. EMG remains the ultimate diagnostic modality. But sometimes if you look very carefully, you can see in a very florid case of cricothyroid paralysis, you can see it is really shortened. You can see here. Now this case, watch the left vocal cord. If you watch carefully, you will see that adduction abduction is normal. But the left vocal cord, now look, this is the most important sign. Normally, if you look here, you can see that the membranous cord is 3/5 of the total length and the cartilaginous cord is 2/5 of the length. But when the vocal cord is so lax because of the cricothyroid paralysis, it becomes half-half. Watch here. The membranous cord is so foreshortened. You can see that this is the gap. I'll play it again. I'll play just once again. You can see the difference. It is so shortened and it is only half the length of the total vocal cord. So this is a very good sign, but you may not see it in all cases. Now, so armed with this much of information regarding the physiology of the muscle and the closure of the glottic pattern, we will go to the neural injury. Now, the laryngeal paralysis or the vocal cord paralysis, whether it is recurrent laryngeal nerve or superior laryngeal nerve, can be proximal or distal. Proximal means high up. So it can be an upper motor neuron lesion, a lateral medullary syndrome where the nucleus is gone. You can see that this is the nucleus of the, you can see that here, this is the area where you get the dorsal nucleus of the vagus, and also you will see the nucleus ambiguous, everything here. So you can see the nucleus ambiguous here. So this is in the lateral medulla. So if a lesion there, that's a proximal lesion. And also you can get high neck injury, like a vagal schwannoma operation, very high in the neck, just say jugular foramen schwannoma. So they all are the proximal type of nerve injury. While the distal type, which we see more commonly when the injury happens near the larynx, like in a thyroid surgery, you can see that it can happen in thyroid and parathyroid surgery, in neck dissection, in cricopharyngeal myotomy, and of course certain other surgeries too, but these are the common surgeries which actually put the end part of the recurrent laryngeal nerve or end part of the supplying nerve at risk. Other the high vagal lesion, the recurrent laryngeal nerve is far away, but it is damage is high up. Now see what is the difference between these conditions. In proximal injury, that means intracranial, a nuclear lesion, or a high vagal lesion. The history obviously will be there, but you also will see, in addition to laryngeal paralysis, you will see palatal palsy too. And you can see laryngeal paralysis, and you can do sensory paralysis of the larynx. You will see so that's a left vocal cord paralysis. This happened after a high stab injury in the neck, but also watch his palate. So you can see that this part is not lifting up. So he has got also a palatal paralysis. So that is one sign. In proximal neural injury of the vocal in the larynx, there will be in addition other findings because obviously the lesion is higher. So even the nerves which control the palate are gone and there will be palatal palsy. And similarly, there will be pharyngeal paralysis too. Again, another left vocal cord palsy, but in addition here, you also see pooling in the left piriform fossa. That suggests the left thyropharyngeus is not contracting because it is supplied by the pharyngeal plexus and the lesion is higher. In addition, if you touch the arytenoid, you will also see that the superior laryngeal sensation is gone and even recurrent laryngeal or the inferior laryngeal on that side. So there will be palatal palsy, there will be pharyngeal paralysis, and also there will be sensory paralysis of the larynx. Now, in proximal injury again, so that means a high lesion, either in the nucleus or high up in the neck or in the skull base. It may be, we know that the classical classification, it may be a neuropraxia, it may be an axonotomesis, it may be a neurotomesis, depending upon the size, the lesion. So it actually decides the recovery. And laryngeal synkinesis is not very common here. We will come to this time little more in detail little later, but I hope you all know what is synkinesis. Synkinesis is a very common phenomenon in larynx, where in neural injury, misdirection of fibers happen. Fibers destined to the adductor go to the abductor and vice versa. And that creates a useless or functionless regeneration of the nerve. Nerve regenerate all right, but the regeneration is not in the order. The physiology is not very good. But in proximal injury, incidence of laryngeal synkinesis is much less. It is actually distal. We'll come to that. So this is a proximal injury. This is again a lateral medullary syndrome. You can see that the right vocal cord is paralyzed. There is plenty of pooling in the saliva. They have even overflowing penetration aspiration there. So this is a proximal injury. Now we come into the distal injury. This happens when the injury occurs very near the larynx. We call it recurrent laryngeal nerve because it is comes around either the ligamentum arteriosum or the subclavian and then come back in the neck. Once in an operation theater, I just asked one of my assisting staff nurse why it is called recurrent laryngeal nerve. Then she was a junior. She suddenly told, because even if you cut the laryngeal nerve, it will regenerate. I laughed heartily, but later then when I thought, she told without knowing the answer, but there is some meaning in it. Recurrent laryngeal nerve has got a very high incidence of regeneration. Roger Crumley, who has done lots of research on this field. He has even removed a segment of the recurrent laryngeal nerve in rats. And we have seen that, he has seen that actually grow back. So regeneration is the rule rather than the exception. So when you do a thyroid, you can see the recurrent laryngeal nerve. You have to identify the recurrent laryngeal nerve. If it gets damaged, The problem is that it will, the rule is that it will regenerate. Definitely there will be an anatomical continuity. But the problem is that synkinesis, which we talked about a little earlier. It actually produces misdirection of fibers. If misdirection happened, this regeneration is useless most of the time. It may not be always, so it can create problems. So that is what is known as a synkinesis. Misdirection of neural fibers in the different into the target muscles. So a nerve branch or nerve bundle destined to the posterior cricoid node will go to the thyroid node and vice versa. So then when patient wants to, when it is inhaling, instead of abduction, the vocal cord will adduct and create a lot of problem. So that is what is known as synkinesis. Now, synkinesis is likely to happen in the more severe type of injuries. So it is less likely to happen in neuropraxia, maximum likely to happen in neurotomesis and axonotomesis. So what is happening is that this is a basic principle. The denervated laryngeal muscle, they are very hungry for the neuronal transmission. They want the acetylcholinergic fiber. So they will attract the neuronal sprouting from any nerve. It need not be the recurrent laryngeal nerve and superior laryngeal nerve alone. Any other nerve in the vicinity, they will be attracted. So there is neuronal sprouting there, and actually it will go to the muscle. That is how this problem occurs. You can see that in a neuropraxia, many times it goes to the same fiber, same muscle. Nothing will happen, only small injury. But in a bigger injury, this is damage here for a long distance. So they don't find the real pathway. They go haphazard and go to the wrong muscle. So that is the synkinesis. Now, we have seen that this is more common in severe type of injury, that is axonotomesis and neurotomesis, but much less common in neuropraxia. We told about Roger Crumley. He has done tremendous studies. And Crumley has classified synkinesis, sorry, I have written synkinesis, is actually synkinesis into 4 types. But I am just going to mention here, discuss only 2 major types. I think otherwise I may be confusing you. So this is probably most important. So I'm just taking the major chunk of Crumley's classification. So you can have an adductor synkinesis and you can have an abductor synkinesis. What do you mean by adductor synkinesis? Means the adductor muscles in the larynx get the chunk of the neuronal sprouting. So recurrent laryngeal nerve is cut. It actually grow again. And when that growth regeneration happens, maximum number of fibers actually go to the adductor. Normally that is the case. In a normal larynx, 70 to 75% of the muscle mass is by the adductor. Posterior cricoid node, the abductor provides only around 25%. So consequently, the neuronal fibers also, it is designed like that. 75% of the fibers are for acting during phonation or exhalation, and only 25% act during abduction or inhalation. And in adductor synkinesis, what happens is that vast majority of the fiber actually go to the adductor. So what will happen? The vocal cord will have more adductor tone. It may not be adducting, but the vocal cord will be in the near adducted position. So you can see that it is something like this. Don't worry, this video doesn't have voice. But you can see that the right is moving, left is paralyzed, but it is actually in the midline. So because it has got a regeneration and the synkinesis, the adductor synkinesis has happened, so that the left vocal cord, even though it is immobile, it has got good tone and it is in the midline position. This is what is known as the adductor synkinesis. Now you can get the opposite. This is not very common, abductor synkinesis. Here what happens is that many of the fibers actually destined for the adductor actually go to the abductor when the regeneration happens. consequently, what will happen? The affected vocal cord will have more abductor tone and it will be more paramedian or more lateral in the position. You can see that now there is a gap there. It is not completely closing, and obviously in a unilateral vocal cord palsy, this kind of abductor paralysis will have more voice problem because the vocal cord is in an abducted position. But there is two more type where adductor and abductor are equivalent, and the fourth type where there is a flickering. But for your purpose, I think right now you should think about try to understand mainly. There can be adductor synchronesis, there can be abductor synchronesis. This is what happened. So what is, again, I am just coming back to the concept. If recurrent laryngeal nerve is injured peripherally, chances are that it will grow back. But the regeneration almost always happen. Occasionally it can grow back straight away, especially in neuropraxia. But in other injuries, some kind of synchronesis or misdirection of fibers happen. And in the misdirection of fibers, there are two major striking types. One is the adductor synchronesis, where the most of the fiber actually go to the adductor, so that the vocal cord is in the adducted position. Even though it is not moving, it has got good tone and it is in the adducted position. While in the abductor type of synchronesis, the vocal cord actually is more in the abducted position and it is away. It also has the tone, but the problem is that vocal cord is away. Okay, now with that much of information, we go to the next level. Now results will be different. Now we are going to take each condition, different condition one by one. First, think about a unilateral recurrent laryngeal nerve injury. And in here, I am going to show two left recurrent laryngeal nerve injury following thyroid surgery. The first patient had an adductor synchronesis and the second patient had an abductor synchronesis. So what will happen? An adductor synchronesis patient will be practically asymptomatic because he or she will have excellent voice because the vocal cord has got good tone. It is in the adducted position. The second patient, because the abductor synchronesis is more, the vocal cord is more lateral. There is a phonatory gap. The voice will be bad. So we will see same type of injury, but different result. So the first is the adductor synchronesis, where the paralyzed left vocal cord is in the midline. No thyroplasty, nothing done. Patient has got a very good voice. Now, in abductor synchronesis, so you can see that when patient is trying to phonate, the left vocal cord, instead of coming medially, it goes away. And patient will have bad voice because the gap is there. So this is the issue. Patient has got the vocal cord has got the tone, but it is the abductor tone. So voice will not be very good. Now we go to the bilateral recurrent laryngeal nerve injury. Now there are three scenarios. Both sides has got adductor synchronesis. So what will happen? Both vocal cords are immobile. They have got good tone. They are in the adducted position. Patient will have very good voice, but patient has got woefully inadequate airway. So this is what many times people outside ENT don't understand. You know, many times we hear anesthetist and general surgeons telling, we did the thyroid surgery, everything was okay. After the surgery, patient is speaking very well. How can it be a vocal cord paralysis? They don't understand that. But it is quite possible. So this patient has got a bilateral adductor synchronesis with the result that the vocal cords are in good tone. They meet very close to each other. They have got good voice, but their airway is very, very inadequate. Now, the other type, the second type, in bilateral recurrent laryngeal nerve, both sides develop abductor synchronous. This is not very common. So they will not come to you for difficult breathing, but they will come with a very poor voice. So watch this video. It's got a bilateral abductor synchronous. You can see the tone for the abductor is good. Actually, it is in abducted position. Patient doesn't have any breathing difficulty, but patient has got very good voice. Now the third group. One side has got an adductor synchronis and the other side has the abductor synchronis. They will have both voice and airway neither very good or very bad. They may actually go on for long time without taking any treatment because their voice is not very bad or not very good. Airway is not very good or very bad. So they will go like that. So watch this patient. One side has got an adductor synchronis, the other has got an abductor synchronis. So if you look carefully, you will see that the right has got an abductor synchronis and the left has got an adductor synchronis. So that's the three types. So in unilateral, you can get two type of cases where the paralyzed code is in adductor synchronous or abductor. Of course, there are subspecialties, but I think right now they being a preliminary type of introduction, I think this is the best thing. In bilateral, you can have both adductor synchronis, both cases showing abductor synchronis, one case showing adductor and one abductor. Now coming to the SLN injury. Trichothyroid palsy prognosis is not that well researched. That's a problem. This is a very difficult area. This was actually a case of bilateral external laryngeal branch following thyroid surgery, injury to external laryngeal branch. But one actually right recovered, left didn't recover. Even now you can see some bowing is there on the right, but it has recovered. So it is not that well researched superior laryngeal. Now we come to the second, the laryngeal reinnervation. Now, laryngeal reinnervation is the hot topic in laryngology aspects today. It is fast developing, concept is evolving. So we'll talk about it. Before that, we go to the great Ishiki, with whom I had the fortune to get a photograph when we were in Korea. Now, Ishiki conceptualized and described the laryngeal framework surgery. So for unilateral recurrent laryngeal nerve and unilateral or bilateral SLN palsy, he actually devised surgeries. Or the surgeries devised by him had solutions for these conditions too. So what Ishiki did was that he didn't bother to correct the basic issue. That means the basic issue was the nerve. So he conceptualized that you need not actually correct the basic issue. You can actually correct the result. You need not correct the cause. You can actually correct the end point and then get the best result. That was possible. He brilliantly showed that by doing modification of the laryngeal framework, he could actually get excellent results. And we know that the major laryngeal surgery for the vocal cord paralysis was for unilateral vocal cord. See, one was the medialization thyroplasty, which he called the type 1. Like we put a window here, put an implant, push the paralyzed vocal cord inward, whether it is an abductor syngenous, whatever it is. The gap is filled close with a suitably sized implant. And if there was a posterior gap, he also did what is known as the arytenoid adduction, but what we now call is arytenoid rotation. The principle was brilliant, taking a suture through the muscular process and anchoring it in the direction of the pull of the lateral cricoarytenoid. And for bilateral superior laryngeal or even for unilateral, he could also advise cricothyroid approximation or type 4 thyroplasty, tensioning thyroplasty. So all these laryngeal framework surgeries could correct to a great extent the problem caused by the laryngeal paralysis. Later, newer techniques were added, like injection laryngoplasty. Of course, I should tell that even before thyroplasty was conceived, in 1913, Bruning did the first injection laryngoplasty, but then it was forgotten. Now we have got a lot of injection laryngoplasty, especially as an outpatient procedure. It has become very common now in the laryngology. Outpatient, you can different approach. You can do supraglottic. That means you go through the thyroid membrane and under visualization inject. Mind you, this is all office procedures under local anesthesia. The assistant is doing the scopy. We pass through the superior thyroid space, inject inject into the paraglottic space and medialize. You can inject transthyroid. You can also inject cricothyroid. I previously used to inject cricothyroid, but my preferred technique right now is thyroid. Previously, it was taught that, in older people, in ossified cartilages, you can't do that. That is not really correct. You can actually, by selecting the right needle, you can always inject through even the ossified cartilage. I don't generally prefer the thyroid route because it produces some amount. If there is some bleeding occur, it is very difficult, and a patient can gag loud. Vision may not be good. The only good thing about is that this is the only injection technique where you see the tip of the needle. Here you are only seeing the tenting. Here you are not seeing at all. You are going underneath the vocal cord. But I will prefer this. Anyway, everybody will have their own choice. And also the rare group where we saw that interarytenoid paralysis, or there is a very posterior phonatory gap, then actually you can do this surgery known as the adduction arytenoidopexy. You can actually take the body of the arytenoid, open up the cricoarytenoid joint, take a suture through the cricoid and arytenoid and fix it medially so that the posterior gap is closed. So a lot of things happen in laryngeal paralysis. And in superior laryngeal nerve palsy, you could do, whether it is unilateral, bilateral, you can do cricothyroid approximation. This is usually done for androphonia, but you can be done for this too. So this is the thyroid cartilage, this is the cricoid. So you take two sutures on either side, tie over a silastic bolster and completely tighten the cricothyroid together so that the tension is increased. But there were problems. There were problem cases. Not every case of laryngeal paralysis, unilateral vocal cord palsy, could be actually corrected by thyroplasty. The major problem were the three groups. The first group was, there were cases where there was a vocal cord paralysis, but plus total loss of tone. None of the laryngeal framework surgery actually can give tone, even though people have suggested that you can combine type 1 with cricothyroid approximation or arytenoid actually give tone. That's not really correct. The real tone, you have to have, the muscle has to have the tone. So when somebody has got a total loss of tone, thyroplasty is not going to work, like this case. So you watch carefully, you can see that this is both, and see the vocal process level, the lateral cricoarytenoid level, it is perfect. It is closing very well. Only there is a gap in the anterior tooth there. So you might argue, why don't you do a thyroplasty alone? You can do thyroplasty, but still the vocal cord is lax, is sagging. thyroplasty will not improve the tone. So this is a troublesome group. That is the first group. The second group is the professional voice user. A singer comes to you with a vocal cord paralysis or paralysis. Thyroplasty will improve the speaking voice, but the singing voice may be troublesome because you need to change the pitch. The vocal cord actually changes the position. So if there is no good tone, adductor tone, you may not have very good voice. So that is a second major group. And the third group was pediatric population because of two reasons. One, you know that previously, most of the time we used to do the thyroplasty under heavy sedation and local anesthesia. Of course, now there are better medicines like dexmedetomidine, which will actually keep the patient very quiet during surgery. So you can take more time. But the second major problem was that pediatric larynx is growing. So even if you do an implant now, say 5 years down the line, you may have to refashion it because the larynx has grown, the vocal cord has grown, the gap has worsened. So you may have to do that. So because of these reasons, pediatric population also were not the ideal candidates for the laryngeal framework surgery. So we have seen that three groups. When there is no tone, when a professional voice user like a singer or actor is having a vocal cord, unilateral vocal cord paralysis, and when a child is having a vocal cord paralysis. So what you do, you go for the non-selective reinnervation. Aim is very simple. You get a good adductor tone. Now remember Crumley's adductor synkinesis. So here what we want is that you don't want a mobile cord. We all know that in a unilateral vocal cord palsy, it is not very important that the vocal cord is moving. You need to have a vocal cord which is in the medial position and with a very good adductor tone. So if you can connect a nerve which will fire during exhalation or phonation, either to the laryngeal adductor muscles or to the remnant of or the distal segment of the recurrent laryngeal nerve, patient will have actually very good voice. This was a singer. She had an idiopathic vocal cord paralysis, and you can see that. So if you look carefully, you can see the left vocal cord is moving, but it is bowing. There is no tone in the thyroarytenoid. Even at the vocal process level, it is not meeting. So lateral cricoarytenoid also is weak. But the interarytenoid is okay. So this is a singer and it is a vocal cord paralysis. Obviously, I can't do a standard reinnervation because recurrent laryngeal nerve you can't afford to cut it is because it is part of the other muscles are working. So what I did is that I did an injection laryngoplasty with the fat in the theater, and I also did a sort of a very selective highly selective reinnervation. Means what I did is that I took an ansa cervicalis and just connected to the thyroarytenoid muscle. I want an adductor tone. So it is again a non-selective reinnervation, means you are actually not giving abductor. You just give an adductor tone, but I couldn't connect to the nerve. So I just connected to the thyroarytenoid. So this is 4 weeks after the fat injection and the reinnervation, non-selective reinnervation. And you can see that the left vocal cord is yellow because of the fat. The gap is less, but still voice is not very great. When you do any type of reinnervation, it takes sometimes 3 months to 4 months because the nerve grow at a rate of 1 millimeter per day. Now 4 months down the line, this was the picture. tone is much better, both for the thyroid node and the lateral cricoid node. And this singer, who has not been singing for 2 years, her voice was so bad. He was a professional singer. This was her voice before surgery, very breathy. Now 1 year after the surgery, now she is back to singing on the stage. You can see even she's singing high pitch without any difficulty now. So non-selective reinnervation means you reinnervate the adductors with ansa cervicalis. It is just like the adductor syncytius. So you might wonder why you are anastomosing ansa. Why don't you take you connect the cut ends of the recurrent laryngeal nerve? Answer is simple. Recurrent laryngeal nerve has got only 70% of the fibers acting during exhalation. 20-30% go to the abductor. So if you connect the cut ends of the recurrent laryngeal nerve, what happens? You need not, you cannot be sure that all the 70% adductor fiber will go to the adductor muscle. Instead, part will go to the abductor. So the adductor tone will be less. While ansa cervicalis has got 100% fibers, which fire during exhalation only. So there is no problem. If you connect ansa to the remnant of the recurrent laryngeal nerve, it will give only adductor tone, both to the adductor and abductor. So adductor muscle will get excellent tone. And in unilateral vocal cord palsy, you are not bothered about abduction. You need a vocal cord which is well medialized and which has got an excellent tone. That is what Crumley's type 1, see the adductor syncytius. That is what we are going to create, the effect of syncytius. Here we are actually using a 10% adductor exhalation firing nerve is connected to the recurrent laryngeal nerve, and you can actually get excellent result. And another good thing is that they are very near to each other, and good size match between recurrent laryngeal nerve and the ansa. Results are generally very good to excellent. The quarter success rate internationally is around 94%. Mine is also same. We have done around 18 now till now. Results are generally really very, very good. So here you can see that patient had a big phonatory gap as well as a very poor tone. So we actually did the thyroplasty or medialization and also did the, sometimes we just do the anastomosis alone. So here you can see the being anastomosed and a fat sleeve is kept around. You can see that fat is kept around the anastomotic site. Now coming to the bilateral RLN palsy. This is altogether a different problem. In unilateral vocal cord palsy, you need not have a mobile cord. You need only the cord which has put a good tone and in adducted position. In bilateral, that is not good enough. You need to have the mobile cord. You need both abduction and adduction. Mere tone is not good enough. All the surgeries right now available for the bilateral cord palsy improves one at the expense of other. If you improve the airway, the voice is gone. If you improve the voice, airway is gone. So that's a bilateral cord palsy and treated by the standard Kashima's operation. Can be the voice airway is better, but the voice has come down naturally. So then what we should do? So here comes the concept of bilateral recurrent laryngeal nerve palsy, selective reinnervation. So other one was non-selective for unilateral. Why you call it non-selective? Because you are not going to differentiate into the adductor abductor fiber. You give all the tone to the adductor. You want only an adductor tone. Here you need the abductor fiber going to the abductor muscle and adductor going to the adductor muscle. So this is again the original concept was from Roger Crumley, but then Professor Sean Paul Murray actually improved it upon and he developed the concept. So what he did is that he innervated the abductor, that is the posterior cricoarytenoid, by a powerful inhalation nerve, that is a phrenic nerve. You know that the phrenic fire during inhalation because the diaphragm has to contract. So he take the upper roots. There are 3 roots. So sometimes 2 roots only. Yesterday's case, we had a case yesterday. Sometimes they're very flimsy roots, but generally you will have more than 2 roots. So you take the only 1 root from one side, so that the rest of that part of the diaphragm is normal and other diaphragm also is normal. And you do use a Y connection cable graft. You actually innervate both the posterior cricoid. It is actually a nerve to muscle. At the same time, the remnant of the recurrent laryngeal nerve is still there. To that, we give a very weak firing adductor nerve, ansa hypoglossae. Not the ansa cervicalis. Ansa hypoglossae is connected to the remnant of the recurrent laryngeal nerve. Mind you, in non-selective reinnervation, we connected ansa cervicalis to the remnant of the recurrent laryngeal nerve because we needed a very powerful adductor tone. But in bilateral, we don't want a very powerful adductor tone. It may actually, antagonize the effect of the abduction created by the phrenic nerve. So we give a very, very weak adductor firing nerve, that is the ansa hypoglossae, which is a branch of the hypoglossal, but it's actually a branch of the cervical plexus. It's hitch kick through the hypoglossal. So how do you do? First, you do the selective denervate the larynx. First, you have to remove all the unnecessary synchinases nerve and identify. So this is the phrenic nerve. We can see that this was the classical case. Not in every case you get. We have done till now 7 cases, but you can see the 3 roots: the upper root, the C3, the C4, and C5. So you take only this root. You transect here. So the rest of the phrenic is intact. So there is no diaphragmatic paralysis. And using a cable graft from there, using the great auricular has got a Y branching, at the face. So that can be easily used as the Y connection to the both posterior cricoarytenoid. So from the single phrenic nerve root, the great auricular will go and get connected to both posterior cricoarytenoid. So that means if it works well, it will open up the posterior cricoarytenoid during abduction. Now at the same time, you also take out ansa hypoglossae. So you can see this is a submandibular salivary gland. This is the external jugular vein. You can see that, and this is the ansa hypoglossal. You can see that this is the hypoglossal nerve, and that branch highlighted by that blue paper. This is the ansa hypoglossal, which actually supplies the thyroid muscle. So you identify the ansa hypoglossal and again use another cable graft to connect to the remnant of the distal segment of the recurrent laryngeal nerve. Mind you, this has to be done on both sides. So the right recurrent laryngeal nerve is connected to the right ansa hypoglossal. The left recurrent laryngeal nerve is connected to the left ansa hypoglossal. But phrenic you take only on one side because you don't want to paralyze. If paralysis happen both sides, it can be a very tricky situation if diaphragm is paralyzed. So why? Then you might ask, why you really bother about this adductor at all? You can actually leave it alone. What is more important is an abductor. Some tone adductor will invariably happen. We have seen that the nerve has got the laryngeal muscle has got the power of attracting the nerves nearby. So even if you don't do any anastomosis for the adductor tone might still come. But then why do you want to do the ANSA hypoglossy? Because to give adductor tone, not only to give adductor tone, but also to prevent adductor fiber attracting the fiber from the phrenic nerve, thus preventing synkinesis. So this is a competitive inhibition. So you are taking ANSA hypoglossy and giving the adductor. Look, you are also being given nerves. So they are not hungry for the neuronal transmitters. So if they are not hungry, if they are given already another nerve, they will not attract sprouting fibers from the phrenic nerve which is coming nearby. If adductors are left unattended, the problem is that sometimes they will attract fibers from the phrenic, which we have not done so much of pain to dissect out and to put it into the posterior cricoid node. So if the adductors are left alone, untouched, uninnervated, they will actually attract fiber from the abductor too, and the result may not be very good. So to prevent, it is sort of a competitive inhibition. You don't want the adductor to attract any fiber from the phrenic graft you lift. That is why you use a very, very weak adductor nerve. You are not going to answer cervicalis. That is more powerful. You have seen that. It gives excellent tone in unilateral vocal cord palsy, non-selective. But this is a selective reinnervation. And obviously, not as predictable as in non-selective rehabilitation. The biggest group in the world is by Professor Mary. He has got excellent results, 70-75%. And I think there are one group in China, they have got a very good number. There is a group in America. Then there are all over the world people who have done less than in single digit number. And we have done till now down 7 cases. Yesterday's was the 7th case. The first 4 cases, the first 3 cases, I could actually decannulate the patient. But I was not really that happy because the abduction was minimal. They were just okay. They didn't have much problem. Their stridor improved, everything improved, but it was not very good. 4th case actually failed. I didn't actually have a good result. I couldn't actually decannulate. But 5th and 6th case, 6th is actually a child, a congenital vocal cord palsy, 4-year-old child. They are doing very well. And we are seeing actually better result. With the time, with the experience, your learning curve gets better. And 7th case was done yesterday. I hope it also will have good result. This is one of the case. I will just show what is something like this. This is the preoperative picture. You can see both the adductor and abductor, and also you can listen to the voice. Now this is after around 9 months. So that much is there. So this kind of, now the last 2 cases are even better than this. So hopefully we will start getting more and more results, but it is not comparable to the non-selective reinnervation as of now. All over the world it is like that. Non-selective has got the success rate quoted is around 95%, while in selective reinnervation in the best hand, that is in Professor Mary's hand, it is around 70%. Now, superior laryngeal nerve palsy, reinnervation results are generally very unsatisfactory. I don't have any personal experience. So right now, the choice is not very great. You have to do the type 4 thyroplasty. So this is in a nutshell about the current concept of laryngeal paralysis and the reinnervation procedures. It's a real hot topic in laryngology. I'm sure that it is going to come to hold us the center stage. Of course, there will be newer development might happen, something like a neurotransmitters. They all might go out of fashion. We don't know. It is fast changing. It is very, very exciting area. And I am thankful, especially to my teachers. Of course, I never had the fortune to meet Professor Roger Crumley. He is the man who actually began all these things. So he's still very active. He was supposed to come to the neurolaryngology meeting in Germany this year. I also had a plan to go and meet him, but then COVID upset everything. I couldn't go there. But these two teachers, they have taught me. This is Professor Jean-Paul Marie from Normandy, France, who is the biggest name in Reinnervation. And I learned the technique under him. And this is the other great, the Dr. Andreas Müller from Jena, University of Jena in erstwhile East Germany, or right now in Germany, who actually conducts neurolaryngology courses every year, and he is actually developing the laryngeal pacemaker. So all these people have contributed greatly to the development of neurolaryngology, and hopefully it will keep on improving, and we all will learn with them. Thank you.
Thank you so much, sir. It's a wonderful presentation, sir. Sir, in the chat, there are some questions. Can I put up, sir?
Yeah. I have to share. And yeah, I need to stop sharing.
You can just stop share, sir. That's enough.
Already done. Okay, fine. Yeah, questions, please.
Sir, one of the questions regarding subject is from Dr. Nitya. How to differentiate abductor palsy from adductor synkinesis?
Abductor palsy from?
Abductor palsy from adductor synkinesis.
No. I think that concept. So we will have to just get away with that old terminology of abductor palsy. There is nothing like that, right? So don't, that abductor palsy, adductor palsy, all that concept is gone. It is a vocal cord paralysis. Even that terminology is gone, because we have seen that there is some amount of, not a total paralysis. So the current terminology is impaired vocal fold movement. So there is nothing called a bilateral abductor paralysis. That is an old terminology. We don't know. So don't do that. This is a bilateral impaired vocal fold movement, or you can, if you want to call bilateral vocal cord palsy, fine, or bilateral vocal cord paralysis. Now, when both vocal cords are not moving, obviously you call it a bilateral vocal cord palsy. If the vocal cords are more in the adducted position, you call it an adductor synkinesis. If both vocal cords are in the abducted position, you call it an abductor synkinesis. Or sometimes it may be, one may be in the adductor synkinesis, one may be in the abductor synkinesis. So you got confused because you still use the terminology of abductor palsy. Nothing like that. Just leave away that terminology. Shouldn't be using that. That's the concept.
Okay, sir. Thank you, sir. As of now, that's the only question, sir. But you have so many congratulatory messages in the chat box, sir.
Thank you.
Yeah, sir.
If they want, I can understand, because for the postgraduates, that this may not be that easy. That is why I didn't go to the different types of synkinesis classification. I don't want to confuse them. I wanted to present as clear as possible, because this is an evolving topic, and I know that most of them may not be actually exposed to this. So that is why I took like a rather protocol type of thing. So if they have got any doubt, they are free to ask me by sending to my WhatsApp number, same number. No problem. You can give it.
Thank you, sir. So just now,
we have enabled unmute option. If any of the PGs or consultants want to ask, they can unmute and interact with the speaker.
there are just a couple of questions which came just now, sir. Okay. One is by Dr. Vidya. It is like, how long do we have to wait to get the results of both reinnervation surgeries?
Yeah, reinnervation, we see that the nerve grow at a rate of about 1 millimeter per day. So usual time is somewhere around, you should say that somewhere around 3 months is the minimum, and it actually can go up to 18 months. And it is much better in younger people. The rate of regeneration is actually diminished in older people, means above the age of say 50, 55, and also people who have got diabetes mellitus. So these people may not have very good results. So right now, we won't take a bilateral vocal cord palsy for by selective reinnervation if patient is above the age of 60 or a patient is uncontrolled diabetes. Otherwise, usually take minimum 3 months. Unilateral, you have to take 3 to 4 months.
Okay, thank you, sir. Another question by Dr. Samir. Is there any foreign body reaction in type 1 medialization thyroplasty?
Not really. No, I think I have done nearly somewhere around 350 thyroplasties till now. I think there was only one single case where there was a persistent fistula, sinus tract thing. I think it was due to some problem with that particular silastic block. But I opened it up, removed the silastic block and put another silastic block. I didn't have any problem. I don't think they developed. No.
Thank you, sir. A question by Dr. Nadia. In patients with thyroid carcinoma with neck dissection, complicated with unilateral vocal cord palsy without synkinesis, would you proceed with reinnervation or do you do laryngeal ENMG prior to reinnervation?
No, I didn't get that question. Can you read it again?
In patients with thyroid carcinoma with a neck
Yeah.
dissection and complicated with a unilateral vocal cord palsy without synkinesis, would you proceed with reinnervation or do you do laryngeal ENMG prior to reinnervation?
Now, there are multiple factors. First of all, I need to know from the surgeon whether the nerve was anatomically intact or not. If that is not available, leave it. Then the question is that you do the flexible laryngoscopy first. And usually by flexible laryngoscopy, you know whether the tone is there or not. So if there is an anterior phonatory gap alone, you know that only thyroid node is gone. If the vocal process are not meeting, you know that the lateral cricoid node is not there. If the vocal cord is very flappy, flaccid and bowed, then you know that the tone is not there. So if at least minimum 6 months gone and there is no improvement, if the tone is not there, I will certainly combine the procedure with a reinnervation. If there is good tone, doesn't need not be an adductor tone. If the tone is very good, that means the vocal cord is fairly stiff enough, only phonatory gap, then I will do only thyroplasty. But if the tone is bad, if it is very flaccid and curved, then I will always do the reinnervation. Now the question of the EMG is very, very important, but it may not be practical in our setup because not everybody is familiar with the EMG. But EMG will actually give a clue whether this is a fibrillation potential or whether it is an imminent regeneration by seeing the polyphasic potential. But usually we don't do any of these procedures before 6 months because before 6 months the chance of recovery is there. So before 6 months, if you want to improve the voice straight away, I will always do the injection laryngoplasty temporarily because it will give 6 months. You will get more than 10. Then after the 6 months, if the patient is still have a vocal cord paralysis, the voice is bad, then I will decide upon the choice of the surgery, whether it is thyroplasty, rotation, or combined with reinnervation, depends upon these factors. Where is the gap? Anterior gap, vocal process gap, or how is the tone?
Thank you, sir. So another question by Dr. Ravi. What is the best management for idiopathic unilateral vocal cord palsy in a 12-year-old?
In a 12-year?
Yes, sir.
Yeah, the only thing is that in a child, I told that right now we try to prefer non-selective reinnervation. The results are very, very good. I got 2 teenagers, both of them did very well. But the only problem is that the timing of the surgery. When are you going to do the surgery? Because the usual the saying is that in an adult, at least 6 months. But I have seen that after 8 months, I have done a thyroplasty and then the later vocal cord recover. So that has happened in an adult. So theoretically, it can go up to 1 to 1.5 years in an adult, but generally after 6 months we do. Children, the literature say that the chance of recovery can be even longer. Even after 1.5 years, it might recover. So the question is that when are you going to do a procedure like reinnervation? When you are doing non-selective reinnervation, you are going to cut the recurrent laryngeal and then connect answer to that. So it is never going to come back unless you are very sure that this is not going to recover. You will not do a non-selective reinnervation. So till then, I will do injection laryngoplasty or thyroplasty and medialize it.
Thank you, sir. I think those are all the questions for today's webinar, sir.
Thank you.
So with those words,
Can I ask please? Can I ask one question, please?
Sure.
Yeah, please, sure.
Yes, sir. Please. When do you expect the sign kinesis to happen after surgery? If general surgeon done thyroidectomy, and after that the patient was phonating good and everything, when you expect the sign kinesis to happen after surgery?
Exactly like the nerve regeneration. We told that it actually grow back at 1 millimeter per day, and it usually take around 3 months. So synkinesis usually happen after 6 weeks, or somewhere around 6 weeks to 3 months time.
Yes, 6 weeks. Okay. Again, please. You said if you choose the proper syringe, you can inject through the thyroid cartilage. What do you mean by proper syringe? What do you prefer syringe for that?
Not syringe, needle.
Needle. Yes.
Yeah, right.
Yes.
Because the problem is that the cartilage will be ossified, and the older you get, it become more and more ossified. But they usually it's like thyroplasty. You mark the window and externally, and through the anterior part, the anterior half of the window usually will not be ossified. But if it is still ossified, what you do is you first infiltrate the skin with xylocaine, 2% xylocaine, and also infiltrate the external perichondrium with xylocaine, because external perichondrium is very, very sensitive to pain. So you anesthetize not only the skin, but also the external perichondria, and then wait for 2-3 minutes. Okay. Then you take a 21 gauge needle.
21.
Ordinary needle, 21. You need a bigger needle. 21 gauge needle, either an ordinary IV set needle, or you can even use a lumbar puncture. Lumbar puncture. 20. Then you just puncture the skin at the site of anesthesia given and reach the internal perichondria. Of course, you have marked the surface marking of the vocal cord window in that position. And once you reach the external perichondria, you keep on doing the goring movement, the rotating movement. It will actually perforate the thyroid cartilage.
Thank you.
Sir, one more question has come. Any role of speech therapy post reinnervation surgery by Dr. Samir?
No, speech therapy, or the correct word should be voice therapy. The voice therapy role in vocal cord paralysis, the voice therapy, the unilateral vocal cord paralysis, the role of voice therapy is to, when the gap is very small, you can actually design certain exercises which will actually improve the compensation by the normal vocal cord. Okay. While the gap is very big, the voice therapist's role is prevent the patient developing abnormal compensatory status. If patient has got a 4 millimeter phonatory gap, whatever voice therapy you do, nothing is going to happen. So there the voice pathologist's role is make sure that patient is not developing abnormal compensation like ventricular band reduction or arytenoid coming anteriorly. Because if they develop, even if you do a very proper thyroplasty later or reinnervation later, this secondary muscle tension dysphonia will stay there for longer, and it will be very difficult to correct. So this is the wrong concept many people have got. The thyroid, not every patient, just because the surgery is not possible, voice therapy cannot be done. Voice therapy has got very, very clear cut rule. A smaller gap, you can always do voice therapy to improve the compensation from the other side. And the other thing is that the brilliant thing about the voice is that voice has got 3 parts. The actuator, that is the force, vibrator, that is the vocal cord, resonator, that is the resonance. So if in vocal cord palsy, what is gone? The vibrator. But with proper voice therapy, if you can improve the force, the actuator part, and if you can improve the resonator, you can still get a good voice. So voice therapy is in selected cases, it is very useful. It is not a must for everything. In some cases, it has to be defensive, like not allowing the patient to develop abnormal compensation. After the reinnervation surgery, when patient is recovering, it is very important that either the voice therapist or laryngologist see the patient regularly and advise them regarding what all things you can do, what all things you shouldn't be doing.
Thank you, sir. Another question by Dr. Ravi. Post vocal cord nodule excision in a singer, there is an inability to sing higher pitches. I think what should be done is the question.
So that question itself is there is a big problem in that question. You are not going to operate on a vocal nodule. Vocal nodule shouldn't be operated. Vocal nodule is not a surgical condition. Exceptions may be there. Huge vocal polypoidal nodule or fibrous nodule, they are minority. And especially in a singer, there is no question of vocal nodule surgery. It shouldn't be done. This is an important concept. I have been talking many times. Please don't do surgery for vocal nodule. Vocal nodule is a functional disorder. Because the patient has got a bad technique, that the patient developed the thickening, callosity. So if you're doing the nodule excision, you are gaining nothing. Patient will again develop, because why the patient developed patient vocal nodule? Because he had a muscle tension dysphonia. You have to correct that. And when you damage the, when you are doing the surgery, that's not going to improve it. That is why patient is unable to sing the pitch. The problem is that by doing the vocal nodule surgery, what you have done is actually you are treating the result rather than the cause. So the treatment is actually identify, do a singing flexible laryngoscopy, identify what exactly is his technical issue, address it by a person who knows singing voice care, either a laryngologist who is familiar, or a voice therapist who is familiar, or even better still, a vocalist. So don't do vocal nodule surgery in a singer. That can be very dangerous.
Thank you, sir. I think that's the end of the questions. I request the audience, if they have any questions, either please speak up or put it in the chat group. And for the webinars, which sir has already given earlier, are present in our Sahasra Foundation YouTube channel. You can go and visit there and see the previous webinars.
Okay.
Yes, sir. I think, sir, we have come to the end of the session and all the doubts have been cleared. Sir, we thank you profusely again. Please for giving us the opportunity and giving the webinar.
Thank you. Welcome. It's a pleasure teaching students. I really like that. So if they've got any doubt, they need not be apprehensive. They can definitely contact me either on my WhatsApp or on my mail. No problem. Welcome.
Yes, I have already shared your mobile number in the group, so anyone can take the note of it and contact.
Thank you.
Sir.
And good night.
Thank you so much, sir, and have a good night, sir.
Good night.